Shall we start now then? I think there's about 40, no? Can you hear me?
Yes, madam, we can hear.
Okay, so I'll start. Good morning, everyone. I'm Dr. Rangika Fernando. I'm a senior registrar in community medicine in the Directorate of Non-Communicable Diseases. This was supposed to be taken by the director, Dr. Vindhya Kumarapeli, but she's a bit busy with another program this week. So I'll be using her slides. If you have any questions, just ask me as I run through. So I'll talk about the National Program for the Prevention and Control of Non-Communicable Diseases. When we speak of non-communicable diseases, we have actually two areas in our directorate. There's the acute NCDs, which is injuries due to road traffic crashes, poisoning, drowning, and then we have the chronic NCDs, so cardiovascular diseases, diabetes, chronic lung diseases. Cancers actually come under another program, and chronic kidney disease also. The functions are divided between several units. So we all know the risk factors for NCDs. Chronic NCDs can be non-modifiable and modifiable factors. In our prevention, we focus on these modifiable factors. Conventionally, it was tobacco, alcohol, unhealthy diet, and physical inactivity. But the focus on environmental risks, such as air pollution, is now increased. The burden of NCD in Sri Lanka, these are WHO statistics. So NCDs are estimated to account for 83% of all deaths. And 34% is due to cardiovascular diseases, 14% due to cancers, 8% chronic respiratory diseases, 10% injuries. When we talk about surveillance in Sri Lanka, there's a 5-year survey called the Non-Communicable Disease Risk Factor Survey, also known as STEPS. So it uses the WHO stepwise approach to NCD surveillance. It's a national household survey study, which uses multi-stage cluster sampling, and the group included is all adult Sri Lankan males and females 18 to 69 years of age. So the one available is the 2015 one, where there were over 5,000 respondents. The 2020-2021 data is currently being analyzed, so that should be available soon. So according to this, you can see the figures. Over 14% had raised blood glucose or are currently on treatment for diabetes. Then you can see for the total high cholesterol, high blood pressure on treatment for hypertension, overweight or obese. And then we calculate a 10-year CVD risk, which is based on age, sex, blood sugar. And so that for those in the age group 55 to 69 years is 13.5%. So as you can see, this is quite a high burden of disease. And we have, in addition to the morbidity and mortality, when you look at expenditure-wise, we do spend quite a significant amount of our health budget on treatment of these diseases, on the management and treatment of complications. So as always, prevention is better than cure. So we look at preventing the risk factors. So the STEP survey also gives us data about the risk factors. So when we look at current tobacco users and the alcohol users, and then it also looks at those who have more than 5 servings of fruit and vegetables a day, and physical inactivity. So there are definitions for all of these. I suggest that you have a look at this STEP survey to get a more in-depth idea. And also with respect to COVID. So this is in the data from the COVID situation report in September last year. So as you can see, of those who died, Majority had some form of chronic disease, comorbidity, and the percentages are given here: diabetes, hypertension mainly. So you must have heard about the Sustainable Development Goals. Globally, all countries have committed to achieving these goals by 2030. So there's 17 goals. When we speak of health, the main goal is goal 3, to ensure healthy lives and promote well-being for all at all ages. Although there are a few other goals that are relevant to health. So goal 3 has 13 targets. One specifically for NCDs, which refers to the premature mortality between 30 to 70 years of age from NCDs. So our target is a 25% reduction from our baseline value of 17.6% by 2030. So when you look at this graph, you can see that the target is given, is the circle given, the global target. And if you look at the graph, you can see that we are still not reaching that target. If you take the projection as we are, our current performance, we are not actually going to reach that target for males or females. So the NCD unit, or the Directorate of NCDs, was established in 1998. All our work is guided by the National Policy and Strategic Framework for the Prevention and Control of NCDs. This is from 2009. It's currently revised. So probably this year, the revised Policy and Strategic Framework will be out. And all the activities are guided by the National Multisectoral Action Plan. Now, as you know, NCD prevention and control, it's not just the work of the health sector. We require involvement of a whole lot of other sectors, including like transport, education, urban planning, agriculture. So I will just give you a small, can you see this? I switched the PDF, you can see this, no? The Global Action Plan. Anyone?
Yes, ma'am.
Okay, so globally, because of the big burden of NCDs, there's a global action plan for the prevention and control of NCDs. And this was, so the World Health Assembly endorsed this in 2013. And it focuses on 4 NCDs and 4 shared behavioral risk factors. So based on this global plan, all countries were expected to set national NCD targets for 2025, depending on the national situation. So there are 9 voluntary global targets. So first, like I said, a 25% relative risk reduction in risk of premature mortality from cardiovascular diseases, cancer, diabetes, and chronic respiratory diseases. Then also it talks about reduction in the harmful use of alcohol, insufficient physical activity, mean population intake of salt or sodium, current tobacco use, raised blood pressure to halt the rise in diabetes and obesity. Then with respect to the management part and the health system part of it, we need to ensure that at least 50% of eligible people are receiving drug therapy and counseling to prevent heart attacks and strokes, and 80% availability of basic technologies, essential medicines in both public and private facilities. Sri Lanka has adopted all of these 9 targets. In addition to this, we have a 10th target, which is not explicitly given in any of the documents, but it's a general understanding to address household air pollution. So go back to this. All our actions are guided by the National Multisectoral Action Plan, as I said before. And you can see, for example, how different sectors are involved. For example, when we're promoting physical activity, you can see that in addition to the Ministry of Health, We also need to collaborate with Ministry of Sports, Ministry of Local Government, and other units. So when you're planning, like town planning, you need to include spaces for walking, public transport, all of that. So there are 4 main areas: advocacy, partnership, and leadership, health promotion and risk factor reduction, early detection and management of NCDs and their risk factors, and surveillance, monitoring, evaluation, and research. So I'll talk about our functions in these 4 areas. So these are mainly of our directorate, but you must remember that other units in the Health Ministry and other ministries and other sectors, civil society, everybody is actually involved in the national response. So these are the targets, as I described earlier, and this is how we implement our policy. So at the national level, we have the National NCD Council, which is chaired by the Minister of Health. So the Minister of Health sits with other ministries, not necessarily ministers, it's usually secretaries or additional secretaries. And this is the overall body leading the NCD prevention and control. Just under that, we have the secretary who chairs the National NCD Steering Committee. So this is also with multi-sectoral engagement. And then from the technical side, inputs are given to these 2 bodies from the National Advisory Board for NCD, which is chaired by the Director General of Health Services. So this basically recommends, based on evidence, based on feedback, based on the surveillance, it recommends certain things to be taken up by the National NCD Steering Committee, National NCD Council, and it's supported by the Technical Working Group. So this is basically the Directorate of NCD together with professional colleges. So recently, for example, guidelines for management of diabetes in primary care and management of hypertension in primary care, all these, and guidelines for referral from primary to secondary care, they were all developed by the Technical Working Group and put to the National Advisory Board for NCD. So this is important also to monitor, because not only do we need to do the work, we need to make sure that we're keeping to our targets, and we need to monitor the progress towards our targets. So these bodies are also responsible for that. At the provincial level, we have the PD, the Provincial Director of Health Services, which is responsible for the activities in his province. So we have 9. And then district level, we have the Regional Director of Health Services, who is supported by the Medical Officer Non-Communicable Disease in each district. So there is a District NCD Steering Committee, which is co-chaired by the District Secretary and the Regional Director. So this, within each district, now each district may not have the same requirements, may not have the same areas to address or same problems. So within each district, the multi-sectoral action plan is taken into consideration according to that district. So in certain districts where we have, let's say, a higher proportion of estate population, or in certain districts, the lifestyle, for example, the diet is significantly different, obesity is higher, they take these into consideration, and this is basically looked at by the District NCD Steering Committee. Then strategy 2, health promotion and risk reduction. We look at these risk factors. So on the healthy diet, our responsibility, the functions on the healthy diet are actually divided with within the Health Ministry with the nutrition unit, and outside the Health Ministry with several other sectors, including the Agriculture Ministry. And so in general, we have a few main messages which we take to the public. So salt, to limit the intake to less than 1 teaspoon per person per day. Sugar, a maximum intake of less than 6 teaspoonfuls. So these are flattening teaspoons per person per day. And to completely avoid trans fat intake as much as possible. So there are several strategies as we work towards these. So there was a national salt reduction strategy, And one of the main things is this front of pack label regulation. This is not just for salt, also for sugar and fat, but I'll talk about that in a little bit. Then there was a mass media campaign to reduce dietary salt over the last few months. Sure, you must have seen it on TV, and the radio adverts will start shortly. And also we need to advocate to the food industry to promote food reformulation. So we need to get them to look at other ways where they can make their products healthier, reduce the salt, reduce the sugar. And so this is trans fatty acids. So there's a strategy called Replace. If you're interested, you can read about it. This is a global one. I'll talk about front of pack labeling. So this is a more recent development. So this basically, this is for, you can see, for sugar, for liquid products. I'm not advertising any of these, but these are basically just a few pictures from some products available in the market. So for liquids, we need to show how much sugar is there in the liquids. And in solid and semi-solids, the salt, sugar, and fat is marked. So the cutoffs are given here. And what we advise the public, obviously, the best is to go for a product where all three are green, but unfortunately, we don't have such products commercially available. And so what we advise is to avoid food items with red logos because there's a high risk for NCDs when using these products. And if there's even one amber logo, it's still dangerous. So there is the education about this to the public is also very important because they need to know how to utilize these when selecting foods. Next is physical activity. So physical activity is any bodily movement that increases energy expenditure above resting levels and includes our day-to-day activities as well as exercise. So this can include general household activities, sweeping, washing, gardening. The WHO recommendation, this is measured based on WHO recommendations, which is 150 minutes of moderate physical activity per week. So generally you take it as about 30 minutes for 5 days in a week or 75 minutes of vigorous activity in a week. Unfortunately, and especially with COVID, the sedentary behavior has increased. And this is also a risk factor, which is when you're in a sitting or reclined posture for 4 or more hours per day. So what you need to do is every hour, get up, move, walk around a little bit. I think especially with all these virtual meetings and lectures, this has increased. So what the NCD unit does is we train our health staff, so either our preventive and curative sector, we train them on how to promote physical activity in different settings. So 3 settings we look at is the workplace, in any educational institute. So that can be preschools, in schools, universities, and also in the community. So there's training of staff. This is done in collaboration with the Association of Sports and Exercise Medicine. Like I said, it's always multi-sectoral collaborations. We also advocate to other ministries. So currently we have advocated through our steering committee and it was taken up at the council also. So other ministries and other departments also to set aside at least 5 minutes a day to get staff to exercise. So we're actually sending out audio recordings that they can play over their PA systems that direct them to do some physical activity, some exercises that they can do at the workstations. So let's move more, every move counts. Tobacco. Now, tobacco and alcohol, actually, the work of the NCD Directorate is limited in this because it mainly comes under the National Authority on Tobacco and Alcohol. So for alcohol, also the mental health unit is involved in a lot of the functions. For tobacco, our main functions are to establish tobacco-free zones. Initially, this we want to establish in the community, but now, sort of as a reinforcement, we are looking at establishing in workplaces. So the target is each MOH to choose 2 settings and establish tobacco-free zones. So this is, so there has to be a process of advocacy initially before this is done. And then the unit also trains on brief interventions, trains health staff on brief interventions for tobacco prevention and cessation at the primary healthcare settings. And we're setting up tobacco cessation counseling clinics at HLCs. I'll talk about HLCs next. So alcohol, like I said, a large part of the functions are carried out by NATA and the mental health unit. Early detection, the strategy 3, early detection and management of NCDs and risk factors. So we have 2 different centers or clinics that carry out this role. Healthy lifestyle centers, that is for prevention and early detection, and medical clinics, which is for the management. So there are healthy lifestyle centers established in institutions, curative care institutions throughout the country. Currently, there are 990. You can see how it's distributed. Basically what they do is they screen for behavioral risk factors. So the target is actually over 35 years of age, but we welcome those over 20 years of age. So we screen for behavioral risk factors, so tobacco use, alcohol, physical inactivity, unhealthy diets. And then we look at, so through BMI and waist ratio, we look for overweight and obesity. We check the blood pressure, check the visual acuity, and we look at pre-malignancy. So we do an oral examination, either medical officer, it's referred to the dental surgeon, and breast examination. And also to attract, one is to attract the clients, and 2 also as a service. We look at the blood sugar and total cholesterol. So as you can see, the percentage, so each HLC or each institution has a catchment population, that is the population around that institution, and they are given targets for screening. So they're supposed to screen a certain target population each year. And as you can see, so until 2019, screening activities were going quite well, but then unfortunately with COVID, it has dropped. So certain institutions started screening with the vaccination program. But one problem that has been there throughout is because this is an apparently healthy population that we're looking at. So to get them to come into HLCs, to take their time to come to HLCs, and the interest has proved to be a little difficult. So there has been a lot of innovative methods used. There have been mobile screening clinics. They basically invite people from OPD to come for screening, those who are not, who are able to come for screening. Not during COVID, this has obviously decreased a little bit with those with acute respiratory disease, but, and also those bystanders in wards, and also this is issued. So the idea is we have a CHDR, Child Health Development Record, when you're a child, and this goes until age of 18. So the idea is for adults, we have a personal medical record. So each person has this with a personal health number, and this will allow them to be followed up wherever they go. So they'll be screened, and if they're referred to another institution as a higher level hospital, it'll all be done in this. And we're in the process of digitalizing this. So ideally, this should form a continuum which I'll talk about in a little bit. So basically, we screen for the cardiovascular risk, as I said earlier, using these charts. And if the risk is more than 20% in the next 10 years, they refer to a medical clinic. And if it's less than 10%, we screen after 3 years. And in between, if there's between 10 to 20%, they're followed up at the HLCs. So they're given lifestyle modification counseling. In some HLCs, they actually have physical activity groups that they can take part in. And this shows basically the data flow. As I was saying earlier, we are in the process of digitalizing it also. And also, whenever you collect data, you must make sure that there's always a feedback. So there's always a feedback. So it comes up to the NCD unit, which is a central unit, and we give feedback to the district and the institution. So to increase the screening, there's workplace screening for health staff. So in certain government departments, we have established a health corner where either that department itself has staff that run it, or from the nearest institution, a team goes once or twice a week and they do a systematic screening of all the health staff. Then for vulnerable communities like the estate sector, the urban under settlements, there are mobile clinics and also opportunistic screening of BP. So you can see these are health corners. So this is the one in the health ministry. And then other opportunistic screening done. The idea is that people are tempted. Wherever you go to the people and you screen for them at that. So the target group is all people over 20 years. And as I said, these are some ways of getting that target population. When we look at management of NCDs, what the directorate does is we have developed guidelines for management of NCDs in the primary level. So at the primary level, we have two types of institutions. We have the PMCUs, primary medical care units, which is just the OPD. So usually the staff is a doctor, a dispenser, and a minor staff. And although we're trying to put in nursing officers now. And then you have a divisional hospital. So that has inpatient functions as well. So it has the OPD, the medical clinics, and the admissions. And then you have secondary and tertiary level. So these are the guidelines developed, and we train the staff on these guidelines and on management of complications. During the last 2 years with COVID, this actually proved to be a challenge. So there were several decisions taken. So one was, rather than clients coming monthly, we issued medicines for 2 months. And also, rather than monthly follow-up, we together with the technical working group, we looked at which cases you can actually increase the follow-up to like 2 to 3 months, or even up to 6 months. This was all during COVID. And the last one is surveillance, monitoring and evaluation, and research. So we get our data mainly from two sources. One is the healthy lifestyle centers. As I said earlier, all that data comes to the central level. But we must remember that this data is from a slightly biased population, because those that come to HLCs, or even when we do outreach clinics, are those who are seeking health services. And also then we have the STEP survey, but the only problem with the STEP survey now, it's a national representative sample. However, it's only done once in 5 years. So HLC surveillance, we can get real-time data, but we have to understand what the drawbacks are. So we give our feedback and we publish all the data in the annual report, and we have a quarterly NCD report. And as I said, in the districts, we have a medical officer MCD who is responsible for coordinating all the activities in that district. So they coordinate with all the MOHs for the preventive side, and they coordinate with all the primary medical care institutions. They're responsible for training, for implementing new activities, and there's a virtual training platform. Let me just, with respect to management, I'll talk quickly about this. I think I have 5 more minutes for this. So there is a policy on healthcare delivery for universal health coverage, which launched by the Ministry of Health in 2018. So the goal is to ensure universal health coverage for all citizens. And this came in the background of an aging population and increased burden of non-communicable diseases. So this actually required continuity of care, which means that if a person is diagnosed, it needs long-term care. Plus, it needs care. We need to coordinate care from the primary level to the specialized services, from the private sector to the government sector. Even investigations have to be coordinated throughout. So universal health coverage, I'm sure you know this, ensuring that all people have access to the needed promotive, preventive, curative, and rehabilitative health services of sufficient quality to be effective, while also ensuring that they don't suffer financial hardship. So when accessing these services, people should not pay out of pocket, or we should reduce the amount that they pay out of pocket. This is a UHC cube. I'll just make it simple. So where we are at the moment is this green colored box. At the moment, we're in this green colored box, and we want to work towards the outer blue line box. So how do we do this? Like I said, there's 3 aspects. One, we look at the population. So we can increase the population that is covered. So that means we can, for example, if our medical clinics now only are easily accessible to the non-working population because they're held on weekday mornings, we need to look at ways that the working population can access. So either clinics on Saturdays, clinics in the evenings. Then if we look at now vulnerable communities, estate communities, we need to look at how we can cover those populations also. Then next, when we look at services, which services are covered, we need to see how we can increase the services covered. So this can be investigations. For example, now if you go to a PMCU, you may not have had a way of checking your FBS. But what can be done instead, now we can't establish laboratories in all primary medical care units. So what we can do is we can have a system of collecting the blood and sending it to a higher level institution so that the clients can actually check the FBS at the institution closest to home. So by doing this, we also ensure financial protection. So we reduce the amount that a person has to spend out of pocket. So by providing lab investigations, by providing essential medicine, we reduce the amount that a person has to spend on doing a blood test privately, or the amount they have to spend and the salary that they have to give up to travel to a teaching hospital or a high-level hospital that's far away from home. So the services are given in the Sri Lanka Essential Service Package 2019. So for NCDs, you can see this is just a small bit of it. We call a shared care cluster. So a cluster is basically a specialist institution that's a hospital, a DGH, a PGH, a teaching hospital, and it's linked to its surrounding primary medical care institutions. So this functions together as a cluster, and each primary medical care institution has a catchment population, which is a community surrounding it. And it's responsible for this community, for the primary care of this community. And then the Apex Hospital, which has several PMCUs and PMCIs, so PMCUs or divisional hospitals around it. The Apex Hospital is responsible for the catchment population of all of these. So this is shown in this. So you have in blue this Apex hospital is responsible for this entire population, but it is also linked to all of these primary medical care institutions, and each of them has its own smaller catchment population. So when you talk of shared care, there's two things. One, within that cluster, you share resources. So lab facilities, medicines, human resources. Example, if the smaller hospital, the PMCU, doesn't have a nursing officer, on the day of a clinic from the Apex hospital, from the base hospital, a nurse can be sent just for the day of the medical clinic to collect blood, to send to the high-level hospital to do the investigations. Or if there's not enough dispensers, if there's only one dispenser who can't manage the crowd, we can send a dispenser just for that day, just for that medical clinic day. Then the training also, the specialists, so the VPs, VOGs at the Apex hospital, that's the specialist institution, they are responsible to train and mentor the medical officers and the other staff at the primary level institutions attached to their hospital. In this way, the individual's health, so a person's health, is also shared between all of these, and it forms a continuum between the primary care and specialized services. So I won't go into all of this, but the idea behind this, so we are implementing this especially for NCD services. Once you're diagnosed, the primary care doctors should provide quality first contact care, and there's continuity of care through referral and back referral to a supportive network of specialized care services. And between this, all of the resources are also shared. And so this improves, so this gives holistic patient-centered care. We cater to the needs of the patient. And also there's something called citizen engagement and empowering the community for rational health-seeking behaviors. So a client chooses to go to their nearest small hospital if they know that they can obtain all the services from there, rather than spending time and money to seek help in a bigger institution. So they benefit in that way, and the health system, our crowding at the bigger hospitals decreases. We get to spend more time on cases that need specialist care, whereas the smaller hospitals are utilized more. So that's the end of the presentations. Are there any questions?
Excuse me, madam.
Yes.
When it comes to the healthy, for a healthy person, the limit of sugar per day, is it 9 teaspoons or 6 teaspoons?
6. So what we say is the limit is 6. 6 level teaspoons, but obviously that also you should cut down. I mean, that's the limit, basically.
Okay. And madam, this 10-year cardiovascular risk, this document, is it available online?
Yes. So all the guidelines are available on our website. The NCD, just search for Directorate of NCD, you will find the website. I can also share the document. I will email that. I don't have the soft copy with me right now. I can share that as well. So there is for South Asia, there is separate charts, so relevant to our population. So those, I can share the soft copies with you.
Okay, thank you.
Is there anything else before the next section? Okay, ma'am. So then I'll stop now. I'll share the slides. Who shall I email it to? Tishan, shall I email it to you? Okay, I will share the slides anyway. Okay, thank you, everyone.